Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. Thank you for joining us for today's Policy Spotlight with Dr. Ashish Jha. Policy Spotlight is a series of virtual events Health Affairs launched last year, featuring in-depth conversations with influential health policy experts. Among the 16 guests we've had are CMS Administrator Chiquita Brooks-LaSure, FDA Commissioner Robert Califf. Most recently, I spoke with the Director of the Agency for Healthcare Research and Quality, ARC, Robert Valdez. All of these are recorded and can be viewed on our website. Today, I'm pleased to welcome Ashish Jha, the White House COVID-19 Response Coordinator. When announcing his appointment, President Biden said Dr. Jha is one of the leading public health experts in America and a well-known figure to many Americans from his wise and calming public presence. I love that. But it takes more than a calming presence to lead our nation's response to the COVID-19 pandemic, which, of course, unfortunately, as we know, has killed more than 1 million people in the United States. Infection and death rates are nowhere near their peak, but COVID-19 continues to be a leading cause of death and a source of great public attention and concern. Coordinating the federal government's approach to the pandemic and executing President Biden's March 2022 National COVID-19 Preparedness Plan is quite a large responsibility. And so it's a real privilege to be able to spend some time and take time out of Dr. Jha's busy schedule. Ashish Jha was appointed to the position on March 17th of 2022. He came as the Dean of the School of Public Health at Brown University, a role he assumed in 2020. He was on the faculty at the Harvard T.H. Chan School of Public Health and the Harvard Medical School from 2004 to 2020, serving as the head of the Harvard Global Health Institute from 2014 to 2020. He's led groundbreaking research on Ebola, has been a trusted voice on COVID-19, and has advised state and federal policymakers. Dr. Jha has a MD from Harvard Medical School and MPH from the T.H. Chan School of Public Health at Harvard, has written more than 50 articles in health affairs alone over the last 15 years, not to mention a few other well-regarded publications. We've known each other for many years. Once I complete our formal introductions, I may slip and call you Ashish, but for now, I'm going to say Dr. Jha. Dr. Jha, welcome to the program. Well, so glad to have you. To our audience, if you're listening live, there is a Q&A button at the bottom. I will try to weave your questions in if possible. I make no promises, but I'll do what I can. So let me just start with this. This is such a dynamic pandemic. Things change every day, every week. We could spend an hour talking about where we are today, and 2 months from now, probably this recording would be of limited value to our audience because things would have changed so much. So I would be remiss if I didn't ask you a little bit about where we are today, but I want to say to you and I want to say to the audience, I really want to talk more about what it's like to be in this role and some of the issues you confront, things that I think will be of lasting value to our audience. And I just want to say that up front. With that as an opener, how do you feel about where we are as of December 12th, 2022?
Yeah, well, first, Alan, thank you for having me here. And let's definitely keep this to Ashish and Alan conversation. We have known each other for a long time, and I am grateful to spend some time. I mean, the health affairs audience is an audience I know well. I am a member of that audience and love this opportunity to spend some time talking. Where are we on December 12th, 2022? So kind of at a very basic level, if we just start at the ground level, what we're seeing is infections ticking up across the country in most places of COVID. Obviously, this is in the backdrop of one of the worst flu seasons in a decade, and RSV, which has been, we've had a lot of RSV, though I think at this point the data suggests that RSV is starting to come down. But that all said, and then maybe one other piece of context here, Alan, right, which is that this is the third year of COVID, of this pandemic. And what that means is we have a healthcare workforce that's pretty spent, that's very exhausted. We have asked doctors and nurses and others to dig deep and do extra shifts and take extra, and that is, at some point, that the ability to keep relying on that has been difficult. So that really does create a set of challenges for us. I think in terms of COVID specifically, the way I look at where we are today, I think, again, with infections rising, there's a series of things that we can do that will influence what happens next. And then there's a series of things that the virus is going to do that are largely outside of our control. Right? The virus continues to evolve. How it's going to evolve? Are we going to see some other major new variant? Things that we don't know. But things that we do know are that we are at a place in this pandemic where people are up to date on their vaccines. People are getting treated. People are using basic precautions, wearing, masks in super crowded indoor poorly ventilated spaces, using testing for large gatherings. We do some basic things. We can make an enormous difference in terms of keeping infection numbers lower, certainly preventing serious illness. That stuff is under our control. And I think that's going to be a truism moving forward, that there's going to be more and more things that we can do under our control to manage things, but obviously the virus continues to have its own X factor, and it's really hard to make predictions about exactly where the virus is going to go.
Well, I'm not going to ask you to make predictions, but I think that's a good backdrop to the more thematic topics I'd like to cover that, as I say, I hope will have some lasting value to the audience. So let's start with what it even means to be a coordinator in the White House. You come out of academia, not exactly the federal bureaucracy, although I hear that academia has its own bureaucracy. Talk about what the management template is. What's the management role? How do you even command resources sitting in the White House?
Yeah. So it's an important point, right? That the title is coordinator, and that is actually a very good description of what I do and what the job is. And a lot of this was watching my predecessor, Jeff Zients, who I think did this brilliantly for 15 months that he was in the role. We have federal agencies that are scientific agencies that make scientific determinations, right? We have an FDA that's a regulatory agency that decides what vaccines get authorization, what treatments get authorizations, what gets approval, diagnostic tests. We have a CDC that looks at the evidence and data and makes proclamations and makes determinations of who should be eligible for vaccines or treatments, or a whole host of agencies. The key is, and that's just within HHS. Then there are all these other federal agencies that have significant roles. OSHA thinks a lot about labor safety, right, and kind of safety of workers. You have DHS and Department of Homeland Security that has TSA and other. So the point is, there are lots of federal agencies that touch on the COVID response. And the reason President Biden created this role of a COVID response team led by a COVID coordinator in the White House was because COVID had such a profound impact in so many parts of our society that we needed an all-of-government response. And so the key thing that I spend my time thinking about is that all-of-government response, and making sure that it is not at odds with each other, actually ideally that they amplify each other, that they work together. So what labor is doing and what DHS is doing is aligned with what HHS is doing. And that it takes a lot of time and effort to make sure that it's an all-of-government response. But the upside is, when it is well coordinated, the impact of the federal government on this virus and getting the virus under control, reducing illness and death, is quite profound. And because the federal government is a very powerful force, can do a lot of very good things if it works effectively in a coordinated way. And what I have learned, and I don't know that I appreciated this before this pandemic, certainly, is that the White House works best when it plays that coordinating role. That it's the one place in the federal government that can see across all the agencies and thinks about how do you integrate all these different efforts. Otherwise, you have every agency kind of off on their own, doing their thing, sometimes coordinated, sometimes not. And the White House, when it's functioning at its best, is playing that coordinating role. It's complicated. It's an awesome responsibility, but when it works well, it really does have impact.
So one of the things we often don't think about in government policy, I love that you mentioned all the different agencies, but they each have different goals and objectives. And there certainly are fundamental decisions about how to respond to COVID, where one agency, looking through its own lens of its own priorities, its own constituencies, would reach a different conclusion about what to do than another one. And we talk about, following the science, but the science doesn't answer the values questions. It doesn't answer the political priorities questions. So how does that part of not just coordinating, but aligning. How does that work?
Yeah. So it begins first by having very clear goals of what we're trying to accomplish. And by the way, I get those from the president. Like when I sat down and met with the president to talk about this job and the conversations we have, he sends very clear signals about what the goals are, right? The goals are start with reduce the suffering and death that the American people have suffered in this pandemic. Keep death, serious illness as low as possible, and keep driving at that. I think that's sort of very, very critical. Obviously, do it in a way that causes and do it in a way that keeps the virus level so that it has as little disruption on our society as possible. And with very clear goals of trying to reduce morbidity, mortality, disruption, it becomes a bit easier to begin that coordinating effort, right? Because if you don't know what your goals are, then it actually can be hard. It can be harder to do the alignment. The alignment, what I have found, and in the 9 months or so that I've been doing, 8, 9 months that I've been doing this job, is a lot of it is just conversations. It's trying to understand what are OSHA's goals versus what are CDC's goals versus, and then finding the place where all these agencies can come together to kind of further the very clear goals that we have as an administration. And like in my mind, it's work, it's conversation, it's negotiation, but we have been able to, on every topic that has been put in front of us, get to a good spot where everybody says, yeah, like this aligns with our goals, this aligns with, and you're right, like any individual agency, if they start left to themselves, may not have gotten to that exact same place. But I feel like we've been able to pretty consistently get to places where people feel good about the policy decision, partly because it is aligned with the big picture goals that we have, which is to really reduce the suffering and death that the American people have suffered in this pandemic.
One of the things I'm trying to imagine in your position is the balance between short-term mitigation of harm, as you described, and long-term, or maybe a medium and long-term planning. If you want to break some news today, you can tell us when the emergency will end. But if you aren't prepared to do that, maybe you can at least tell us what the discussions are about how to handle the unwinding of some major provisions. And one of the members of the audience asked about the number of people who will lose insurance coverage. That is one. We've seen reported in the news, of course, concerns about how much treatment costs and how folks will cover those. So that sort of medium term, and then of course the planning for the next. And by here, I'm not so much thinking the mutations of the virus, but really the next major unknown assault on our health system. So
Yeah.
we need to be looking today. We need to be looking 6 months. We need to be looking 6 years. How do you balance those three?
Yeah, so I think that's exactly right, and we do all of that. So let me give you, obviously, as I started with, we're seeing an increase in cases. We're seeing actually not just cases, increases in hospitalizations in many parts of the country. And so we have people spending a chunk of my time today. I was doing calls with some major cities and governors. We've got more of those coming, talking to them about, like, what do you need? What do you need tomorrow? What do you need next week? Where can the federal government help? And we've got some of our ideas, they've got theirs. Very short term, but very, very important part of, we got to get through this period of time. I don't know how long it'll last, when we're going to see this increase, but we got to manage it. And that is active. In the background, and not so far in the background, we have a group of people on our team who are thinking about the transition to sort of more normal, some people call it commercialization, kind of the more normal way of doing business. You know, the last 3 years, I think very much rightly so, certainly in the last 2 years under President Biden, the US government has been buying vaccines, has been buying treatments, has been buying diagnostic tests. We know at some point that needs to transition. What is that point? Well, that point is driven by a few different factors, not the least of which is lack of congressional funding. Congress has stopped funding us buying these things, so we can't purchase them if we don't have the resources. But also, we are moving to a different phase in this outbreak where where I do think it'll be reasonable to move a lot of this stuff into the normal healthcare market. Our principles, our values on this have been make sure this transition happens in a seamless, non-disruptive way. We want to make sure that people don't all of a sudden wake up one morning and say, oh, I no longer have access to treatment. That would be a real problem. Got to make sure that that's very smooth. Second, have a very clear strategy for both, for cost issues around, look, you and I both know that while 92% of Americans are insured in America, there are still significant cost barriers for a lot of the insured. I do not want a low-income senior unable to afford Paxlovid or unable to afford diagnostic testing and therefore not be able to get treatment, right? Like that would not be okay. So our values are that there should not be cost barriers, particularly for lower income people. And then obviously there are 8-10% of people who are uninsured, making sure that they have access and that cost barriers are not a problem. That is all work that has been going on in pretty vigorous ways, ready for the time when things transition. When will that be? The reason I can't break news today is because I don't know what I would answer even if I wanted to. Like there will come a day when the Secretary of HHS will decide to end the public health emergency. I don't know what that day is. And there will be a set of factors that will go into it. The only thing I know is the Secretary has promised, and we as an administration have promised, that we'll give everybody at least 60 days. So we'll give it at least 60 days, so there will not be a surprise. You won't wake up one morning and the PHE will be over. You'll know it at least 60 days in advance. But the facts on the ground are going to determine when the Secretary decides that the public health emergency needs to. But there's so much work and planning. And then one last thing, kind of thinking about the longer term, Alan, when I think about the burden of respiratory diseases in America, as you know, I have been a clinician, and I was until I started this job. I was attending in the hospital this past January. Every December, January, when I'm in the hospital, even pre-pandemic, our hospitals are full. Basically, flu sort of raises, if you think about the burden of respiratory disease as kind of seawater, raises it to a level where it just kind of gets to the top of the seawall with a little bit of splashing, but we're able to get through every winter. That's pre-pandemic. Throw in COVID on top of that, and we are going to, for years, be challenged to manage multiple highly contagious respiratory viruses. We have got to do long-term things that are going to reduce the burden of respiratory illness. And in my mind, there are two big buckets of things there that we spend a lot of time on. One is improving indoor air quality, which we think is a really important short and long-term strategy. And second is a whole different generation of vaccines and treatments that reduce the burden of, they're talking about mucosal vaccines, pan-coronavirus vaccines. And by the way, they're going to have massive benefits for future pandemics as well. So it literally is everything from thinking about how do we get through this week and next, to how do we make sure we have the technologies to manage whatever comes next 5 years from now. And we've got to kind of be working on all three of those at the same time.
Okay, I want to transition toward talking a little bit about communication, which was, I think, I, along with many others, watched you before you were in this role, and of course, see you in this role. Talk to me a little, if you would, about how you talk about COVID has changed by being in this role relative to when you were outside of government.
Well, there's a lot that hasn't, I think. I think about this conversation, the substance of it, of course, would have been different if I were still at Brown, but I think how I would have talked about the virus, the short term, the medium term, the long term challenges, my suspicion is a lot of that would have been very similar. And my kind of big picture strategy, and then I will talk about what's changed in a second. My big picture strategy throughout the whole pandemic has been, it's not such a strategy, it's pretty straightforward, which is, be plain, talk about what you know, acknowledge what you don't know, and be very straightforward with people about kind of the virus, the state of the virus as you best understand it. And there'll be times when I'll get things wrong, and that's fine. I'll come back and acknowledge it, and we'll correct that. But it's just it's a process of communicating that I think I certainly had tried to have before I came into this job, that I have tried to keep. There are a couple of differences though now, right? One is I'm no longer a academic who speaks only for myself. I'm just not. So I now speak in, part of an administration, and so obviously what that means is I'm thinking about the priorities and efforts we have. I want to make sure that I'm communicating all of those. I do less. One of the big differences, I do less predicting. As a colleague of mine said, I was in the business before I started this job of predicting where the fires were going to be and how big were the fires. And if they turned out not to be true, there was really no big deal. I'm largely out of that business. I am now much more in the business of making sure we have a fire response plan, making sure that if it's a large fire, we're ready for that. If it's a small fire, we're ready for that. When we see fires, making sure that we actually go execute on all of that. That necessarily changes the communication, and appropriately so, right? It's very different to be in a actual execution role and a coordinating role than as an academic where you get to sit back and look at the world and say, I think this is going to happen. So that probably is the biggest difference in my communication is I'm just communicating about different things. And I've tried, and it's interesting, Alan, because even there, sometimes I will say something and people will say, the White House predicts X, Y, and Z. And I'm like, actually, it was not meant as a prediction, but that still happens. But I've largely tried getting out of the prediction business and more focusing on the preparation business.
So I want to ask a lot more questions, but that answer makes me want to ask this. How do you feel now about how much of what you were doing before was being asked to predict? Like, was that a useful service, or do you kind of wish everyone would get out of the prediction business?
No, I'll tell you why it was still useful in some ways, right? Part of it was in the early days of the pandemic. I mean, people had no sense of timeline, what was going to happen. It was so unprecedented. And this is why I think comments, like the virus is going to go away any day now, or we're better, just actually wasn't helpful. And the prediction part that was useful was to be able to say to people, look, after every major holiday, we have seen an increase in cases. We're going into a major holiday. It stands to reason you're going to see. Some of those predictions, I think, were helpful in helping people plan and understand, or saying, this virus is not going away. We're going to be dealing with it for years. So let's make a plan for how we deal with it. I think some of that was useful. Some of the local kind of prediction stuff probably was a little bit less so. But I think giving people a sense of what we were in for, where we were, I think did help people plan and understand their lives a little bit better, because so many lives were so upended in the early days of this.
That's really helpful. And I remember one of the things you would often do is sort of communicate the relative patterns of hospitalizations and fatalities, and that you can sort of see where this is going. That kind of prediction, I think you're right, making sort of sense-making predictions as opposed to broad global predictions about what would happen. That's very helpful. Another key element, and I appreciate you saying that your fundamentals haven't changed. You speak honestly and clearly as well as you can, but the matter of uncertainty seems just overwhelming here, and the notion of how do we communicate about risk and likelihood, and the importance of doing something that won't either definitively prevent or cause, but will change the odds of something occurring. That's always been a challenge for science communicators, but I wonder if you've learned some things about that in this role and how people respond to what you say.
Yeah, it is complicated. I guess, what, one interesting thing that I've tried to do in my life is try to communicate those issues in a very personal way, by telling kind of personal stories of decisions I make, and then trying to explain why, right? And so when I get together with my elderly parents, I will do certain things a little bit differently. I take a test before I go see them. Well, I do not do that if I'm going to go have dinner with some friends. Why is that? Do I love my parents differently? No, it's not about that, right? It's about risk. And it's about understanding that that there's a different risk if you bring COVID to an 80-year-old than if you do to a vaccinated, boosted 50-year-old. They're different. And so helping people understand, and again, and also reminding people that some people will make different choices on this. But I think giving people a sense of what is higher risk, what is lower risk, putting into context of other things that we do in our lives that are low risk and high risk, I think it's much more useful, I find, than like trying to come up with either specific numbers or even using terms like this is high risk or low risk. It's all about lowering risk and where you want to act and where you want to intervene and what is the cost of that action. So I'm not going to not see my elderly parents. That would not be an acceptable kind of intervention because it's just very costly to not see them. But taking a test before I see them is not that costly. It's not that big a deal because if I'm positive, I don't want to see them because that would be harmful, right? So it's just helping people understand that we make those kinds of trade-offs all the time in our lives, and COVID has got to be thought of in the same.
So two areas that have been really complicated in that regard are what does it mean to be fully vaccinated? And some member of our audience got that question in almost the moment we opened the lines and asked about that. And the role of masking, which I remember a time when there was sort of a question of, is it protecting me? Is it protecting you? Is it protecting both of us? And of course, we had the periods of shortages and what's the quality of the mask and all of those things. But both of these are just areas that at one level you'd sort of want to be about as simple. When you talked earlier about what we can do, what the virus is going to do, what we can do, those are sort of basic elements. It seems we would want as simple and straightforward messages as possible. Yet it feels to me like both of them have gotten muddled. Is there a way out on these that isn't just going back into some political morass?
I'll tell you how I think about both of them. So I understand why we used at some point the term fully vaccinated. I think the term that's useful now is, are you up to date on your vaccine? Because and the reason why that's a better term is because the point of vaccines is you're using them to prevent serious illness, death, and reducing infections and transmission. And what we know is being up to date is probably the thing that matters most. And so, if you're an older person, it doesn't matter if you're an older person, but certainly if you're an older person, you have much higher risk. But all of us, being up to date on the vaccine is probably when you look at the data, that's what really seems to differentiate who has poor health outcomes versus not if they get COVID. And for a variety of reasons, that other term still sort of sticks around. But kind of functionally, clinically, from a public health point of view, I ask the question, are you up to date or are you not up to date? And right now, by the way, in December of 2022, what being up to date means is you at some point got a primary series and then you've gotten a bivalent vaccine. And if you have, I don't know how, it just matters less how many shots you've gotten in between, but if you have, you're up to date. And I remind people that, I think about the fact that I've gotten, I don't know, I'm guessing 28, 30 shots of the flu vaccine in my life. I get one every year, right? And I never sort of go, well, I got it last year, so I don't need it this year. I feel like being up to date on my flu vaccine means getting that shot for the fall when it comes out. And by the way, it's not just a feeling. My hospital where I worked for 15 years wouldn't let me come on staff and see patients if I had not gotten my flu vaccine. I had a flu vaccine mandate. It was not a big deal. So I think just thinking about, are you up to date with the vaccine is probably the right mental model. And that's what I encourage people to do. On masking, this has also gotten, I think, unnecessarily complex. Here's how I think about masking. Do masks work? Well, low quality masks don't work that well. High quality masks clearly work much, much better. Again, going back to my clinical experience, I was struck by, I remember one day, this is in early January of this year, I was in the hospital taking care of patients. I had a really sick COVID patient, with COVID pneumonia, coughing up just a lot of virus-laden air. Walked into his room wearing my mask. Also had an eye goggles, but other than that, wearing a mask that is widely available. I was listening to his lungs, and in the middle of it, he had this coughing fit and just coughed coughed on my face. He felt bad. That's fine. I walked out and I took off my goggles and I said to one of my residents, I said, this is where I'm going to count on my vaccine and N95 to get me through it. And it did. High quality N95s that are widely available now. It was not some purposefully special fitted. I literally bought it from a store and was wearing it. Protected me in a pretty high risk situation. I'm confident if I was wearing a surgical mask or a cloth mask at that moment, that would not have been enough. So what I say to folks is, we have a whole series of tools we use for mitigation, for preventing serious illness, preventing infections. Masks should be one of them. They shouldn't be exalted. They should not be diminished. They are one of the tools we have. People should use them when they want to. We don't ask and demand people use all the tools, but the more you use, the safer you will be. I think turning down the temperature on this, remembering what masks are, one important public health tool, high quality masks clearly make a difference. And that if we see it in that context, maybe we don't have to have so many fights about masks.
Well, some of those fights arise from, just this incredible politicization of the entire response. I know we could talk about this endlessly. I also know there are probably things that you might not feel like you can say, but I would just, one of our audience asked a question, and I think it's the right one, which is there a way out, a way forward that reduces the politicization of the nation's response to not just COVID, but future challenges that we might face?
Well, it's a great question. It's a complicated question. I think it's interesting. I think, if you spend a lot of time on social media or listening to certain voices, it may feel like we're incredibly polarized on this. When I talk to normal people, I find, and again, moderate, conservatives, moderates, liberals, majority of people are largely in a bucket of, they understand this was a complicated, novel virus, killed more than 1 million Americans, but we're in a way better place. The virus, especially if you're up to date on your vaccines, poses less of a threat now than it did a year ago or 2 years ago. And that that sort of middle view, in my mind, I think is held by a large chunk of Americans who understand this. And the way I think we continue to kind of promote depoliticization is to talk about this stuff in a very plain, straightforward way. Like we were just talking about masking, or talk about testing, or talk about vaccines. You're gonna get extremist views, I think, but the key here in my mind is stick to the evidence, talk about it in a way that smart non-experts can understand. And I think if we continue doing that, we'll bring more and more people into the fold. You're always going to have some people in the extremes who are going to feel very, very strongly one way or the other. As a general rule, I try to feel like I think about where's that kind of middle ground where a vast majority of Americans are, and how do we communicate this in a way that people understand? This is about their health. This is about staying healthy, staying well. This is not a political identity issue. And as long as we de-emphasize the political identity and focus on the topics at hand, I think we're all better off for it.
Well, I certainly agree with that. I like the notion that it's, we are in an ecosystem, an information ecosystem, where I'm certainly not the first to say extreme voices get the most attention, and it may give us a somewhat distorted view, actually, of how politicized this is, although we would be naive to ignore that. So I want to shift gears and cover just a couple more things before I let you get back to your incredibly important work. Part of the president's plan has a global dimension. And of course, you and I spent a lot of time talking when you were head of global health at Harvard. Just help me understand how you think about, I guess there are two real questions that I have. One is our place in the world in addressing this, and also is our place as a country that could potentially learn from others. What do you see, acknowledging our different political, economic circumstances, but what do you see that you think that's something I'd really like to bring back to the United States? But let's start with the first one, which is sort of our place in the global.
Yeah, and I will there. begin by the president and what he said when he came into office. Like, one of the more odd things that happened in 2020 in the middle of this pandemic is the U.S. government said we're going to leave WHO. Like, first of all, it's just not a good idea, but to do that in the middle of a pandemic is a particularly bad idea. WHO is not a perfect organization. It needs ongoing work, but really, really important for U.S. global leadership for it not just to engage in WHO, but just much more broadly. One of the first things the president did was restore that. One of the other things that he did early on, because it was very clear that the world needed more vaccines, was made a commitment to get the world vaccinated. And, we got, I don't know the exact number, I want to say about 670, 680 million doses of vaccines, by far more than any other country, out through COVAX, through a lot of bilateral relationships. And the point here is not to just like sing our praises on that, but remember what that means. It means in a crisis, you need countries to step up and say global leadership is important, global engagement is important. It's obviously important to vaccinate our own population. It's also important to vaccinate the world. That, I think, has very much been the stance of this administration. And we continue to believe that. And I certainly, you will not be surprised, believe that, given that I spent such a large chunk of my life thinking about global health issues. The line I often use, which is, I think, something I feel very deeply, but I think the president does as well, is that there is no domestic-only response to a global pandemic. Like, you just can't do that. It won't work in the long run. And so I think global leadership, global engagement through vaccines, through treatments, making sure these things get widely distributed, available, supporting countries, supporting multilateral institutions like COVAX, WHO, all of that is a really important part of what the administration has prioritized, and rightly so. And certainly since I have come onto this role, made sure that that continues. But there has been zero resistance, or actually a lot of enthusiasm for that. To your second question of what can we learn, I mean, what's been interesting in this, Alan, is that almost every country has done this a little bit different, right? There is the sort of it's actually not unlike conversations you and I have had over the years on health systems, where people have this mental model of we should do what Europe does in their health system. And I'm like, Europe is not a country, and the Swiss model looks pretty different than the English model, which is different than the German model, right? It's the same thing with COVID response. Or when you look across and people say, well, like the Asian countries, well, a lot of variation between what Hong Kong did versus what Taiwan did versus what Japan has done. And I have always believed in health systems and also with pandemic response is that you can't take any one place and say wholesale importing if our strategy had totally matched Japan's strategy or Germany's strategy, because we are different countries. But there are important lessons around communication, around trust, around, what I have always believed on pandemic response is you lean in heavily on non-pharmaceutical interventions before you have medical countermeasures like vaccines, treatments, and tests. Once you have those medical countermeasures, vaccines, treatments, and tests, you lean less heavily on it. We've seen many countries do that, and I think to good effect. And so I think there are a lot of lessons that we can learn. And by the way, one last point on this, even within our own country, and this also mirrors our health system, it's not like we've had one response. The response of certain states looks very different than the response of other states. And so there's also a lot of internal learning to be done of why do we have such different death rates? Why do we have such different infection numbers? What can that teach us all within the United States? This conversation does start feeling a lot like the health systems conversations we have, doesn't it?
It does. And of course, we've published a lot of what we've learned thus far, and we'll continue to do so. So I was just about to pivot, but a question came in, and I want to paraphrase it and use it. It goes a little bit backwards in our conversation, but someone asked about how hard it is to update measures implemented earlier in the pandemic. And I want to add on to that question with this, which is the trade-off between continually updating standards, like what it means to be up to date in your vaccines, between the trade-off between being up to date with the science and confusing people by saying, oh, well, today it's this, but last week it was that, and next month it might be something else. People are looking for some stability. Not everyone watches the news, and not everyone watches this interview, and so it takes time for messages to get out. But then you can end up with policies that were created when we knew different things than we knew today. Anyway, I just love this question. So I want to squeeze it in here before we finish. How do you think about that trade-off between current and stability?
Yeah, it's a great question. I think about it initially by saying one of the things that we, as a scientific community, needed to have done better, and I continue to think about it and try to work on, is helping people understand that science is a process, not an outcome. That with a novel virus, we will learn new things. And as we learn new things, we will change recommendations. We ought to. That's actually the right thing. And I go back to clinical practice. When I was in the hospital in January of this year, January 2022, I was practicing different medicine than I was in January of 2012 or January of 2002. And you would want me to. You don't want medicine that's like cutting edge from science 20 years ago, right? But there is a trade-off, and there is also the issue of you don't want clinical practice to change based on every new study that comes out, right? That's too much whiplash. So there is always a judgment to make this. When is the evidence now accumulated enough that we need to shift? And when I think about my clinical practice, and let's say how I might treat a heart attack patient, I get one small study of a new thing, I don't immediately shift and say, okay, I'm going to start using this new thing. I wait till the evidence builds. If the evidence is compelling, I would get other experts in. When expert societies say, it's time, it does slow things down a little bit, but it creates a sense of reasonableness. You just have to do that a little bit in a faster timeline with a pandemic. But I think the key to it is explaining to people why. What really has changed? What have we learned that we did not know before? And why is this updated guidance better? I think we don't often make that, help people understand it so much. We just say, now you should do X. And people are like, well, this feels different. And people will do that, by the way. They go back to my tweets of, July of 2020 and say, in July, you were saying this, and now you say this. And I'm like, yeah, it's been 2.5 years. You don't want me to change update my recommendations? But helping people understand what caused that update is really important.
Great. Well, as we come to our waning minutes, I always like to focus a little bit on your own career path and lessons from it and observations from it, both because I think it's really interesting. I don't get to ask these questions that often, and because I hope it'll be helpful to some in the audience. Obviously, you did not go to medical school thinking you would become the COVID rapid response coordinator. I am certain of that because the position didn't exist. But I am curious what you feel in your academic work, both as a student, if you will, and as a faculty leader. What did prepare you? What elements of that make this a good landing spot for you?
Yeah. Well, I don't know if anything really prepares you for a role like this, but I will tell you there are things that have been helpful. As you know, Alan, because you and I have known each other for a long time, I love academic medicine. I love writing. I love science and kind of policy research. I've been very fortunate to have a lot of that find a home in health affairs. But in fact, even that is a window into kind of my thinking. As much as I love being an academic, I've also been a little bit of a skeptical academic. My skepticism from the early days was that the academy overemphasized papers and grants and underemphasized impact. And by the way, that's not uniform. There are places that clearly emphasize impact a lot, but overall, if I had a critique of the academy, it would be that. And my mentors, including people like David Blumenthal and Arnie Epstein and others, said, well, if that's your critique, then build a career that does it differently. And what that meant for me was the reason that I would often want to publish in health affairs is because I spent a lot of time talking to policymakers about their pain points, about their where were issues where data would be really helpful. And what that did was teach me both a lot about the policy process, but also about evidence-based policy. My take has been throughout my career that most policymakers just want to get it right. They actually want to use evidence. They're trying to do the right things. A lot of times when they have to make decisions, they do it in a context where there is no evidence. And part of the job of academics is to show up with the evidence in time for decision making. So if I have to make a decision tomorrow and you give me data a year from now, that's great, not useful. And so, and again, this is one of the things that you have done brilliantly with health affairs, is then become the venue for that kind of work. So what has been useful to me in the years of being an academic and thinking and engaging with the world is really getting some understanding of how policy making happens. I think that's been helpful. Nothing like actually then getting into the arena and actually trying to do it to realize there's a lot of complexity here that you don't always see from the outside. So I've been trying to learn, and obviously getting lots of advice and turning to people who've done roles like this to make sure I'm thinking about things correctly. But I think that's been an important part of how I've made this transition.
You know, someone asked, one of our listeners asked, who do you report to in the White House and how often do you meet with the president? And those are great questions. I'm going to, again, since I'm running the show, I get to expand it just to exactly what you asked, which is when the White House brings someone in with the kind of technical and communication skills that you have, but not a longstanding experience in the government, what resources do they bring to you to say, you focus on what you're good at, we'll help you learn the things that you've never seen before? Like how do you, what's the on-the-job training for being in the White House?
Well, so a couple of things. So I report to the president. I meet with them. I mean, he's got a pretty full plate. I meet with him whenever sort of there are critical issues or we're engaging him on something or he wants to be briefed up on something. And there are lots of ways of engaging the president beyond just one-on-one meetings or in-person meetings. And the day-to-day, a lot of it is my meeting with and spending time with Ron Klain, who's the president's chief of staff. So that's sort of kind of the mechanics of how a lot of this is. You know, on the issue of government experience and what I do and don't have, I always remind people, and this has certainly been true in this case, that you're hiring a team. You're not hiring a person. You want the team to have the set of skills you need to carry out a mission, right? And the notion that any one person will have all the skills that are necessary in a complicated job, it's just like, it's not how the world works. And so when I came into this role, it was very clear to me and everybody else that I did not have 15 years of federal government experience. And so I have a deputy who is absolutely terrific. And she's had a lot of experience in the federal government, at the FDA, at HHS, elsewhere. And so she and I end up being really good complements to each other because there's a bunch of times when I have an idea and I'm like, I think we should do X. And she'll be like, that's not going to work. And I'm like, explain it to me. And then she explains it to me. So I'm like, but we should still try to accomplish this. And she's like, well, here's a different way that we do it. So it's teamwork. And we have a team of people who are a mix of experts, people who had a lot of government experience, and we work really effectively together to get to where we need to go. And it is a reminder that like you don't need nor necessarily want one person on the team to bring everything to the table. That's actually probably not a good idea. But you do want to make sure that the team members complement each other in a way that the team as a whole is effective at the mission that's in front of them.
So other than a deputy and of course, Ron Klain's extensive experience, is there someone sort of like assigned to help with this, or you just kind of make your way along with those around you?
Yeah, it's a very, I mean, this is again, to me, been really interesting. It's a super collegial senior leadership at the White House. And so there have definitely been, and less today than 6 months ago, but definitely been moments where I'm like, I don't really understand how to think about this. And I will walk in to the office of a lot of the other senior people who have had a lot more government experience. How does this work? How do you think about this? And Ron is super accessible. So Ron becomes a really good resource. Times I call up my predecessor, Jeff Science, who has a lot of government experience. And I'll be like, Jeff, when you encounter problems like this, how did you think about it? One of the things I do a lot in this job is constantly engaging people and getting a sense. Scientists, so I'll be looking at data and I'll say, this concerns me, or this doesn't concern me, or this is how and I'll call up 6 different scientists from immunologists to epidemiologists and get their take on the data. And that's one of the privileges of this role is that you're able to do that. People are willing to give their time and effort to help you do your job better because they understand that we're all trying to do this for the same reason. We've got to get this virus under control. We want to reduce the number of people getting sick. And so the ability to tap into that incredible intellectual capacity, both within the government but also outside, is really, really critical to what I do.
Okay, last question. Along your career path, can you identify one or two key decision points where you've chose to go a certain route that you think has been really positive for you being able to move into this sort of a position?
Well, I'll give you a principle of, so when I was finishing clinical training, I was really on the fence about whether to go into academics or not. And I went and spent a year at the VA in central office in Washington, working on quality and thinking about the VA's quality strategy, and learned a ton that year. And also decided I wanted to go actually back into kind of academics and get my research training and then go become a professor. And so I bring that up first for a couple of reasons. One is it taught me that decisions need not be one-way streets. Like, I had initially made a decision to not go into academia and go work at the VA. And a year in, I realized not actually exactly the right decision at that moment. And, leave doors open. And I go back and knock back on the door of the fellowship program at Harvard and said, remember how a year ago I said I didn't want to, what do you think? And then we figured out, how to make that work. So I think that's kind of one part, is just sort of experimenting with different things. The other big one was I had spent my entire career being a domestic health policy researcher. And then in 2015, late 2014, the university, I was at Harvard at the time, asked me to run the Global Health Institute. And I remember thinking, well, this is different. But deciding to go down that path, I think it was enormously helpful in both teaching me things. And so my big picture point is there have been multiple times when decisions have come up that have felt a little orthogonal, a little different off the path. And I've taken them because I've known that if I got it wrong, these are rarely irreversible decisions. As long as you do it with your eyes wide open and don't burn bridges and don't. And that's been really helpful because it has given me a broader set of experiences that I think have been helpful in this role.
Well, Ashish, thank you so much for sharing so much of yourself with me and our audience today. Of course, having known you for some time, I'm gratified to see you in this role, and I feel comfort knowing that you are where you are. The country is better for it. So appreciate your thoughtfulness in all respects, something that has always stood out, and it comes through in how you respond to these questions. It comes through in how you try to communicate about these complex issues. I'm very grateful for your service and your decision to take this challenge on. Thanks again for spending an hour with me. And I'll let you get back to the important things you need to do. I do want to tell our audience that we will on Thursday at 4 o'clock Eastern have a journal club on our December paper by Leah Fernald on take-up of the Earned Income Tax Credit among Californians. A journal club is available to our Health Affairs Insiders, which is a membership program offering exclusive access to content beyond the journal. You can sign up for Insider on our website. We will have a lot more in 2023 with a lineup that you won't want to miss. Sign up to be notified of those events as they come. Again, Dr. Ashish Jha, thank you for being with us. To our audience, thank you for joining. And we are adjourned.
Alan.